Hello, everyone. Thank you for joining me for this GHAPP MASLD podcast series. My name is Lavinia Iordache. I am a physician assistant with 10 years of outpatient and inpatient experience in the field of hepatology, and I am affiliated with the University of Miami. Today, I will be sharing some insight in regards to monitoring for metabolic-associated steatotic liver disease in patients with underlying diabetes. So we know that SLD was chosen as the overarching term for steatotic liver disease of different etiologies. And we can consider here, of course, alcohol use disorder, medications, monogenic diseases. However, metabolic-associated steatotic liver disease has the highest percentage of SLD. And this, of course, correlates with obesity, especially android body fat distribution, with central adiposity and visceral fat, dyslipidemia, hypertension. However, we have to put a special focus on diabetes because insulin resistance is universal in patients with fatty liver disease. And there is a strong association between the presence of diabetes and the risk for progression to fibrosis, as well as the development of hepatocellular carcinoma in these patients. So we will delve a little bit into this topic. There is actually a bidirectional causality between diabetes type 2 and metabolic-associated steatotic liver disease. So essentially, no matter the initial etiology that the patients present with, we should also screen for the other. In patients with diabetes, it is important to monitor their labs. So essentially, CBC, complete metabolic panel, to check the liver enzymes, evaluate for any abnormalities, make sure to exclude the other etiologies of liver disease, such as autoimmune hepatitis or any other viral hepatitis or any other diseases. And it is important to assess for the level of fibrosis using NITs or non-invasive tests. And this will allow for early identification of at-risk patients, which should be referred to specialty clinics in order to allow for timely interventions and hopefully prevent future hepatic decompensations. So the objective of the primary assessment would be to also identify those patients with low risk for fibrosis, which can be safely monitored in the PCP clinic or by endocrinologists. And, the recommendations would be that anybody with low FIB-4 scores, so essentially less than 1.3, can follow up with their primary care providers, and repeat NITs should be done at 2 to 3 years. However, in patients with underlying diabetes, when we know there is a higher risk for progression of fibrosis and other complications, a more appropriate screening should be done probably earlier, like maybe at 1 year instead of 2 to 3 years. This way, we would identify any changes much sooner. So FIB-4 may be the easiest and the most cost-effective test, but we must not forget about the other NITs available for us right now, which would be ELF, the Enhanced Liver Fibrosis Score, which can provide valuable information, and especially the imaging studies, right? The FibroScan and the MRE. So when do we pursue a more thorough evaluation with several NITs, and when do we stop after doing a FIB-4? So, of course, in patients with a low FIB-4 score with no other signs of underlying liver disease, let's say normal liver enzymes and a normal appearance of the liver on ultrasound, except for maybe hepatic steatosis, we can continue to monitor with labs and rechecking the FIB-4. But in many instances, additional testing would be required. So whenever there is any discrepancy between the labs, the imaging, the FIB-4 test, and the appearance of the liver on the ultrasound, let's say any evidence of liver contour nodularity or splenomegaly or recanalization of the umbilical vein, any thrombocytopenia on labs, right, and a low FIB-4, obviously it would require further evaluation and confirmation of the stage of liver disease. So we can employ FibroScan or MRE or whatever we deem appropriate in those instances. Also, it is important to remember that normal liver enzymes do not rule out underlying fibrosis. Many patients with cirrhosis actually do have normal liver tests. And also, the absence of steatosis on ultrasound does not rule out MASLD. So what do we do in these cases? This is where the FibroScan with the GHAPP score, the controlled attenuation parameter, which evaluates for the degree of steatosis, becomes very important in the evaluation. Of course, we know that the MRI-PDFF, the proton density of fat fraction MRI, it would be more exact in assessing the level of steatosis. However, its use is currently limited in the clinical practice. It's mostly used in research at this time. So we talked about the fibrosis staging, the use of different NITs. Patients with more advanced fibrosis or with like a higher risk for fibrosis, an elevated FIB4, for example, probably should be referred to a specialty clinic for further monitoring. So we want to keep in mind not to miss, especially that intermediate patient population where the FIB4 is intermediate, because that's where we can probably make a very big difference in that patient's life. Patients who already have established cirrhosis no longer qualify for medications, for example. But for the intermediate patients with stage 2 to 3, we actually do have a treatment, the pharmacological therapy available at this time. Of course, the resmetirom, which is the thyroid hormone receptor beta agonist, which was approved in March of 2024. The cirrhotic patients are currently being excluded, though the studies are still ongoing. So we have high hopes for this medication for that patient population as well. So lifestyle changes, of course, are going to remain very important, especially in patients with MASLD and underlying diabetes. And any dietary interventions will be beneficial for those patients. So here we can talk about Mediterranean diet. The benefits of Mediterranean diet have been reinforced by the major societies, AASLD and AACE, the Association for Clinical Endocrinology. And they're beneficial not only for improving hepatic steatosis, but also for overall cardiovascular health and improving general health for the patient. Caloric restriction seems to be just as important. It has comparable results to changes in dietary composition. So that's also important. We have to think about calories in, calories out. And on that note, I would mention the benefits of intermittent fasting, which works wonders in some patients, although we have to acknowledge that not everyone will qualify or will be able to do this regimen. We have, of course, the benefits of coffee to remind ourselves of. Drinking 2-3 cups of coffee per day has proven beneficial in reduction of the fatty composition of the liver. Of course, without sugar, without other calorie increasing products. And the importance of exercise cannot be overstated either. So aerobic in particular and strength training have both been proven beneficial in the reduction of the hepatic steatosis. And strength resistance training seems to be doing that by investing less energy. So, it might be better for some people. And they have proven to have results not only at the adipose and muscular tissue, so local results, but also distant effects by improving glucose metabolism, reducing cardiovascular risk, improving cognitive function, as well as immune modulation. So very important to keep that in mind. However, these lifestyle changes come with their own drawbacks, and I think they're easier said than done for many of our patients. There are certain limitations that we have to keep in mind, and we have to work with the patients to mitigate those limitations. They could be physical, psychological, cultural, financial, etc. So I think compliance and consistency are key to achieving success for metabolic associated steatotic liver disease management in general. We can use a scale scale, which is called EDAS, the Exercise and Adherence Scale, which is a voluntary questionnaire containing 33 questions for the patients who want to participate. And this can be performed initially and at 6 months to monitor for compliance. However, on a regular basis, it's easier to recommend, for example, journaling, just keeping a positive mindset and encourage celebrating small successes, which seem to have a snowballing effect. And very important to mention the role of a multidisciplinary approach for patients with MASLD. And here's where I am very grateful to have the opportunity to work together with nutritionists and psychologists, or even licensed clinical social workers that we have working with our clinic to help manage these patients and try to address any possible limiting factors that could prevent them from making a significant enough change to alter their overall prognosis. So if anyone has any additional questions, I'd be happy to answer them. I'm always happy to share my experience about MASLD with my colleagues in GI and hepatology and any other specialties. So thank you for being here, and looking forward to meeting and sharing our insights with all of you. Have a great day.